Welcome to everyone that's joining us. Thanks, Tom. Thanks, Jess. Thanks, Betty. Thanks, everyone from NAMI for having me. As Tom said, my name is Andres Mercado. I'm the Mobile Integrated Health Officer for the city of Santa Fe. And I was thinking my relationship with NAMI goes back about 4 years. I remember the first meeting I went to, it was at the LifeLink in one of their meeting rooms. And I got to share with you all about some of the challenges that you face, either directly dealing with a mental health issue or caring for a loved one with a mental health issue. I have a lot of respect for this group. Improving the system is a really big passion of mine. The goal of improving health and safety is my primary goal in my professional life. So I really want to thank you. It's an honor to be here with you and to share a little background about me. So 6 years ago, I was reassigned from the 911 trucks to explore ways to reduce the risk in the community using the fire department's resources. The fire department's mission is to protect life. So I was very proud to be given this assignment, and I took it very seriously. I'd never really given too much thought to the fact that we have approximately 170 caregivers in our firefighter EMTs that are spread out throughout the city. They're deployed 24/7 with a mobile infrastructure. We have access to real-time and historical data that's essentially city-specific epidemiology. And I'd never given too much thought to the level of trust and access that we enjoy with a lot of at-risk communities. I had taken a lot of this for granted in my, it's now been about 20 years in the fire service, a little more than that. And although the fire department is part of a big bureaucratic, or is a big bureaucratic organization, and it's got an ingrained culture, and it's got a historic focus on time-sensitive and life-threatening emergencies, the opportunities to improve health and safety by just using our standing in our community were too many to ignore. So once this started to really sink in, I didn't have another option. I felt like action was necessary. We built a small team that's data-driven and risk-focused. It's a team of, essentially, it's an operation of intensive case management for individuals involved with public safety. We started just with fire department involved individuals, but we've grown to individuals that the police department is interacting with. This group is called MIJO, and I'll talk a little bit about it in more detail as the session goes along. But through this new perspective, by getting out of the paramedic seat on the fire trucks and on the ambulances, I've learned a lot. I've gained a lot, and a lot of it has been through sessions like this one today. So again, I just want to say how thankful I am to be here with you today, and I look forward to the Q&A session and the input session afterwards. So just to outline the session this evening, I'll give a little bit of background and context about the fire department. I will sort of go through the anatomy of a 911 response, the workflow. I'll speak a little bit about the impact of COVID and available resources. I'll briefly touch on some possibilities that are being discussed locally, and then I hope that we have some time for your questions and input at the end. So a little bit of background about the system in the fire department. Santa Fe Fire Department is a single tier system. So what that means is that the emergency medical services are provided from the fire department. Some cities have the fire department and then they contract with a private company for emergency medical services. In Santa Fe, that's not the case. Everybody is dual trained. So we're essentially an all hazards single tier response agency. In 2019, we ran just north of 17,000 calls. If you do the math, that's about 43 calls a day, and about 40 of those calls every day are medical. But we also do traditional fire department calls, so alarms, smoke alarms, peculiar odors, car fires, and even structure fire once in a while. So as I said, we have about 170 staff who are dual role. That means they're trained in firefighting and emergency medical services. And about 27 of those positions are classified paramedics. That means that they have all the basic firefighter training, but they've also specialized in emergency medical services. So they have the highest level of EMT training available. Our department is split into two divisions. One of them is operations. The other one is support. Operations has the majority of the staff, the majority of the workforce, and handles all 911 responses. Support services is sort of everything else. It's a little bit of a catch-all. And one of the things that's included in support services is the Mobile Integrated Health Officer, MIJO, which is a small team relative to the fire department. We have one paramedic and 2 case managers. They're supported by an independently licensed master's level social worker and by me. And what we do is we focus on sort of longitudinal care for pretty vulnerable patients, oftentimes recurring patients. An analogy that I like to use is we connect the dots. So we look at 911 calls. We also look at events outside of the 911 system and try to create a patient-centered view of what's going on. And then we try and identify if there's anything that we can assist with to improve wellness and reduce harm. So a friend of mine, paramedic, has described the way the difference between just running calls and taking an episodic view of emergency medical care versus doing this sort of work, mobile integrated health work, and taking this more longitudinal view. And when you're just running one call after another, they can be disconnected. They seem to be disconnected. There's no real thread that runs through them from patient to patient. So you often think of it, and I thought of it as how calls fit into my shift. So what place does this call have in my 48-hour shift? And this other approach is more of how does the fire department fit into this person's life? So instead of viewing it from the perspective of responding, it's trying to view it from the perspective of the individual who's receiving services. Having said that, we recognize that the fire department and the city are only part of the systems that are responsible for health and safety. But the city can have a significant impact on that, as any of you who have had to interact with police or fire likely know. And even more indirectly through agencies and programs that are funded by the city through the divisions and committees of the Community Services Department. And even things like urban planning, housing services, all those sorts of things have an impact on health and safety. So the mental health, I think it was 2 years ago now that NAMI had the mental health walk and I spoke at the plaza. And something that sticks with me was this shift in thinking about mental health. I started thinking of it more as a parallel to physical health. So you don't have mentally ill individuals and mentally well individuals. Everybody exists on a continuum, whether that's, so if you're thinking about physical health, there's this continuum from thriving to deep suffering. And that's exactly the same with mental health. It takes different shapes. It affects us in unique ways, but really no one is immune. And mental health, there's sort of 3 buckets in which I'm thinking about mental health right now. One of them is probably what a lot of you may be thinking when you hear someone from the fire department addressing mental health. It's mental health as a crisis or an emergency. So that could be a suicide attempt. It could be extreme agitation. It could be sudden grief of something as traumatic as a rape. It could be an overdose on or withdrawal from psychiatric medications. It could be paranoid psychosis. So essentially an acute crisis or an emergency. Something that's less common, at least a less common association, is chronic mental health issues as a comorbidity for other health issues. So panic disorders, depression, anxiety, PTSD, schizophrenia, all those can lead to drug use, assaults, and they can really complicate the management of other chronic diseases, diabetes, heart disease, et cetera. So I would dare to say that chronic or acute mental health challenges, they have an effect on the majority of 911 calls. So that's a little more under the surface, where it's not so much that the response is for someone in crisis or having a psychiatric emergency, but it truly affects us all, just like physical health. And then a third bucket is one that's not thought about much, but there's some emerging work on it and emerging consciousness around it, and that's the mental health of the first responders. Just to maybe share a little bit about myself. So I was pretty vocationally frustrated by the change in sort of like the job. The job that I applied for was to run into burning buildings and save people that had fallen off of ladders. And I felt vocationally frustrated because that was not what the majority of my interactions with the public were. And I also was pretty continuously, just like most first responders, exposed to human suffering without the tools to do much about it. So that led to a lot of frustration. I was ready to quit. That's sort of what burnout is for a lot of first responders. And thankfully, I was able to channel that frustration towards something beneficial and towards hopefully improving the system. But SAMHSA, to give you an idea, they say that 30% of first responders will develop behavioral health conditions as compared to 20% of the general population. And from coworkers that I've known and from stories that I read in trade magazines, suicide, substance use, domestic violence, and other harming effects of mental health issues are really not that uncommon among first responders. So the 911 system was designed for sort of time critical and life-threatening emergencies. Those are actually the easy ones for us. That's the easy stuff. If there's a cardiac arrest, if there's someone with a broken femur, if there's a car on fire, that's actually fairly straightforward. That's what we're resourced for. That's what we're trained for. That's what we expect. That's sort of what we're recruited for. So the problem is that the requests that come in are oftentimes way more complex than that. So let's discuss what a typical, if there's such a thing, 911 call looks like. So the anatomy of a 911 call, has 5 main components. So number 1 is the event. Number 2 is the 911 call center. Then the response, the on-scene time, and then the disposition, or how that call is resolved or terminated. We'll take each one of those in turn. So the event. We don't usually get 911 calls when things are going fine. And I've heard from many of you at NAMI that having to call 911 or having 911 called on your family member is a pretty scary event. So, I mean, things have typically reached a pretty challenging level. And on top of that, having cops and EMTs show up adds another layer of complexity. And this is why it's so critical that the responders have the proper training and approach, so that we can be a calming presence that actually increases the safety for everybody involved. That's the patient, the responders, any bystanders or community members. And in all but the most extreme cases, these are not mutually exclusive. They're actually, they depend on each other. And there are really a lot of models out there that communities have launched to engineer better outcomes. Colorado Springs, the San Francisco Fire Department, there's a program called Cahoots. There's several promising models out there, but you know, I realize that this is a scary time for family members. But sometimes you need to call 911. So the next step is the 911 call center. So calls that come into the 911 center, there are police consoles and then the medical console. it's actually called the fire console. So the fire department console, the consoles that dispatch fire units, and the console that dispatch police units. And depending on how the call comes in, it'll land on one of those. So once the call, and if it goes into the police side, I'm less clear about which questions, if they have anything protocolized, and I don't think they do. But once it hits the fire console, there's a fairly scripted set of triage questions. Recently, they've added some COVID questions to that, a COVID screen. Some things that you can do during that 911 call to reduce the risk of a negative interaction is to give the best possible information. So that means anything that's a trigger, any history, really anything that can reduce the number of, that can reduce the uncertainty on that scene. Internally, so fire department and police department staff have the ability to add a flag or a note to the dispatch console based on a specific address. That's really limited by the system and the resources that we have in place. But for example, I followed up with a elderly female recently who lives at home, and there were some pretty significant concerns. Visited with her, significant paranoia. She barricades herself in at night. She lives alone. So I was a little concerned about if for some reason we had to gain access to the residence to help her. So visited with her, we learned about her daily routines, sort of her barricade strategy. And then we called the dispatch center and added a flag into her address to give some notice to responding units in a 911 call, areas that they should search first, access points to the residence, some hazards in the residence for conducting any operation inside the house. So that's really available internally to fire department and police staff. But something that Ken Martinez mentioned in the last discussion we had around calling 911 is the smart 911 system. I believe that Tom is pretty familiar with it, and maybe you all are aware of this, but if not, we can make sure that to have some information available for that. And what you do is you essentially create a profile at the dispatch center. It's not in the dispatch center, it's in the cloud. And you can add any information you want to that profile, and then you link it to specific phone numbers and to an address. So if a call comes in for that address, or a call comes in from any one of those linked phone numbers, the call taker will have that screen, that profile that you've created pop up. And then as soon as that 911 call is over, that screen goes away. So your information is only visible if 911 is activated. And there's a lot of information that you can put in there to sort of pre-plan an event. And that's not just, it's broad. I mean, that can help in case of a fire, that can help in case of a medical response. So that's one strategy you can take around just at that step of the 911 call when it's at the call center. After the call center processes that call, they will initiate a response. If there are scene safety concerns, they will activate the police department. They have a policy where sometimes they will only go in if there are 2 officers. And then they'll also dispatch the fire department with an ambulance with 2 personnel on it and an engine with 3 personnel on it typically. Some good news to share on that front is that the police department has 100% compliance with CIT training, crisis intervention training. They did a 40-hour course for each officer, and everyone from their newest cadet to Chief Padilla attended that. So kudos to them. Once the scene is cleared by the police department, so the police department determines there's no scene safety issue, then more than likely that's when the on-scene interaction will take place with the fire department. And the point person who will likely be interacting the most with the patient is the paramedic. They'll provide a primary assessment, which is an assessment to look for obvious life threats. They'll move on to their secondary assessment, asking questions of what events led up to the response, getting a physical exam, taking vital signs, getting a list of past medical history, medications, etc. And paramedics are not behavioral health responders. As a paramedic, I had a lot of experience dealing with mental health issues and a lot of goodwill, but not necessarily the training that I needed. So the assessment strengths that we train EMTs and paramedics for currently lean towards the physical health issues. Something you can do while we are on scene is to continue to communicate the best information possible. So don't count on dispatch to relay that information to us. They're under pressure sometimes. Radio communications can be short and limited. So over communicate. The more certainty we can have around a call, the fewer question marks, the better typically. The last step is making a decision as to what disposition that call is going to have. So whether the patient is transported or not transported, whether the person is going to go to the emergency room, whether they're going to go to jail, whether they're going to remain on the street, or whether they're going to be left at home. Really, at this step of the process, the family and support is huge for us. As you know, really our interactions are typically fairly short. So having family or support for someone who has just gone through something difficult makes it much easier to make sure that beyond whether they go to the emergency room or they stay at home, that they have some longer term support and follow up. So MIJO, with our limited staff, we do follow up, but it's limited, the limited number of patients because of our staffing. And I can speak to that a little bit here soon. So COVID came along and has had some impacts on the system. So just so you know what the state of play is right now, mental health calls, I have a chart here that I'll share with you all. So this is month to month calls that were identified as a psychiatric. Dispatch has different codes that they will assign to a call when a call comes in. One of them is psychiatric / suicide attempt. Dispatch gets it right sometimes, but you know, they really go off of the best information that they have. So these numbers aren't perfect, but they're the closest approximation that we have for trends. So month by month calls for psychiatric / suicide attempt. The ones that are in sand color are the months where calls increased, and the other ones are months where the calls, I'm sorry, the sand colored ones are when we had a decrease in 2020 over 2019. The purple ones are where we actually had an increase. So I was expecting, I know that the first quarter of the calendar year, our call volume was down significantly. I think at one point by about 30%. So these numbers don't take into account the reduction in call volume. So whether it increased or decreased from the previous year, I think as a total of our call volume, this is really rough statistical analysis, but if our call volume was down by 30% and behavioral health calls tracked along with that proportionately, then our mental health calls, our 25s or psychiatric calls, should have also gone down by 30%. So anytime where there was an increase, that's a significant increase because our total call volume is down. And anytime there's a decrease, some of that could be could just be trending along with our decreased total call volume. So it's hard to make much sense of these numbers, but as you can see from the total year to date, about 3% increase in this type of dispatch complaint from 2019. So not enormous variation, or some month-to-month variations, and as you can see, it varies wildly from a decrease of 20% to an increase of 42%. So don't put too much stock in these numbers. They are accurate, but it's not the best radar to use to really understand what's going on. So I think that the take home of that slide is that that is fairly steady as an overall trend. We didn't see, it's hard to tease out anything that we could really attribute to COVID. So with COVID, in effect, expect more questions when you call dispatch. They'll have some really specific COVID questions that are straightforward. These will be asked after the call is triaged typically. So it should not delay response. Something that we're sad about is that mobile crisis response team has been parked literally due to COVID. So we don't have a response from a mental health resource currently. When Presbyterian Medical Services was doing that, they were very active with police department and fire department calls. That contract has since moved to New Mexico Solutions, and they were set to go live in the spring of 2020, and obviously those plans got derailed. So we don't have that resource currently. As far as Santa Fe Fire Department operations staff, just expect more PPE and more precautions, so reducing the number of personnel on the scene as much as possible, putting masks on patients, etc. Hospitals have stricter visitor policies, so if you're planning on accompanying your loved one or friend to the hospital, I'll share some links to their visitor policies. I'll share all this information with Tom and Betty and Jess, and they can put it up on the website or link it at the end of this presentation. But the hospital policies have changed, so just be cognizant of that if you're as you plan what would happen if your loved one or friend has to go to the hospital. As far as MIJO, we're fully operational. About 90% of our time and effort, because of policy and funding, is dedicated to opiate overdose survivor follow-up. That means that we only have about 10% for everything else. But we do provide services beyond opiates. Some of you are pretty familiar with all the programs that we've run in the past, and because of some staffing issues that we hope are resolved at HR very soon, we've had to scale back. But we still retain some capacity to work with individuals that don't have opiate use disorder, and a lot of folks that have mental health issues. We've developed a really strong working relationship with the PMS Bridge program. But again, we're limited by staff numbers. We're nowhere close to meeting the demand or the need, but we are fully operational with our staff. One thing I will ask you guys is, please do not delay medical care. I'm going to share a screen here on some data that came out nationally about out-of-hospital cardiac arrest rates. So pretty big increases in out-of-hospital cardiac arrest. We do not keep track of this this data point, but you can see that some pretty big increases over time on out-of-hospital cardiac arrest rates, and this is due to people postponing required medical care and being afraid of going to the hospital for care. So please do not delay medical care during the time of COVID. It's really important to get any medical issues taken care of quickly. So just to wrap things up, some local efforts that are, some things that are happening. The fire department is in the process of getting a new software system, which we hope will increase this idea of longitudinal care or organizational intelligence. We hope that we'll be able to share this information that we have about individuals with frontline responders, so that when there's a 911 call, they have as much information to go off of as possible. Even when we haven't added after the fact information, if they can even just link previous incidents with that individual, sometimes that gives you access to really important information, medical history, medications, allergies, emergency contact information, that sort of thing. So, so that's something that I'm excited about. We are in the process. I said that one of the reasons we were focused so much on opiates was for policy reasons, and I'm in the process right now of broadening the criteria for how we use those resources to really focus more broadly on public safety case management. Something else that's happening that I'm excited about is the Santa Fe County Crisis Center is set to open in January, and we'll see what happens with COVID, what sort of capacity they open at, but that will be a welcome addition to the system. Something else that's happening is the city recently approved a reorganization of some city departments, and one of the new departments that was created, or the new department that was created, was the Community Health and Safety Department that will combine police, fire, community services, and emergency management. There's a task force that's been set up to discuss this. I believe the first meeting is a week from today. It's on the city's website. So they'll be discussing issues surrounding community health and safety. So I encourage you all to stay up to date with what's going on in the task force and provide questions or input as you see fit. As far as this new department, the city is hiring a director for it. They recently closed the application period for it, and I think a lot of people are really anticipating this next step to think creatively and provide a higher value service to the community. Then my understanding of things that are happening at higher levels in the city, so I'm unclear on timeline, and I maybe won't be able to answer too many questions about this, are the discussion of getting 24 hours of CIT training for Santa Fe Fire Department staff. That would be to augment the minimal mental health training that EMTs get. So again, just tip of the hat to the police department for their leadership on being ahead of this and already getting all their officers trained. But there is discussion about getting the fire department to also have that a similar training. It'll be a shortened training, but similar training. And then a big structural sort of engineering change that is being discussed is a behavioral health response team. So this was mentioned several times during the budget process and reorg discussions. Colorado Springs has a model, San Francisco Fire Department has a model. There's several across the country. And I think it's smart to experiment with different models to scale that are more tailored for 911 call demand, because really we need to get our care models and our conveyance. So not only what we provide, but how we get it to the scene, we need to get that better aligned with community needs. So I'm hoping this has been helpful. Before we go to questions, I just want to reiterate that my respect for the NAMI folks. I think your presence, support, and love for your families and friends are irreplaceable medicine. I have a ton of respect for what you guys do, for your love, for your perseverance, your toughness, and that's why I can never say no to Tom when he asked me to join you guys. So I think it's maybe a good time for questions and input. So Tom, Jess, I'll hand it back to you to open it up to the group.
Thank you very much, Andreas. Thank you for an excellent talk. Jess, do we have any questions coming in on Facebook yet? You're muted, Jess.
Not yet on Facebook.
Okay, well, let me throw it open to the Zoom audience. Betty, I see your hand raised.
Question about the mobile crisis response team on this. You said that they're kind of basically non-operational right now, or are they? The last time I talked to Omar Vega, he said they weren't out on, I mean, they're actually not doing in-person services, but they are on the phone doing virtual. I'm not sure how that works in a crisis situation, but I wondered, is there I mean, do you guys ever call them in a crisis situation just to get their take on things, or is that just not an interface you have right now with them?
Yeah, so thanks for that, Betty. And yeah, as a point of clarification, they have staff. Omar is, I think, their point person for mobile crisis, but they are literally parked. They are doing a lot of work at Consuelo's place, the Midtown shelter, but they are unavailable for the 911 response. So I was speaking about 911 response, and I thank you for clarifying that. So they are available for virtual consults. I think that's mainly email and phone. Again, we work pretty closely with all providers, including New Mexico Solutions when it's appropriate. So when I say we, I'm talking about MIJO. So we work with New Mexico Solutions, we work with PMS Bridge, we work with Lifelink, we work with Joe at Pete's, we work with everybody, reentry folks at the county jail. As far as the scene response, they have not integrated that. In this era of telemedicine, I think there could be opportunities to do something innovative to get someone virtually to the scene, but that is not something that has been rolled out through operations, and I am not aware of any responders, whether it's police or fire, that are using the telephone services. There could be some opportunities there, but I think they're limited. The physical presence is enormous, as you could probably imagine.
Well, are they parked because of COVID, or are they parked because of staffing, or?
My understanding is that their limitations are due to COVID.
Oh.
Thank you very much.
Thanks.
Do you have any other questions for Andreas? Okay, well, I've got some questions. Oh, go ahead, Betty.
No, go ahead, Tom.
No, go ahead.
Well, I was wondering about, we haven't heard too much more since last April when we visited the behavioral health observation unit at Christus St. Vincent. What are you seeing any benefit to that when you're taking somebody in? I think they're able to stay in that unit for like 72 hours. I mean, are they more apt to take people now? I know there was an issue for many years with not even taking people, but now they've got this whole unit that's dedicated to behavioral health issues.
Yeah, I would probably direct that question to Mary Bednar, the ER director at Christus St. Vincent. I realize that they have some space there, and I think that they're doing more consults, the CD consults, chemical dependency consults, and they have some staff, maybe I believe some peer support workers. The MIJO team interacts with folks at the hospital pretty regularly, folks in the ER, both at Christus and Presbyterian. But as far as their workflow and their capacity and how they're using that capacity, I can't really speak to that very well.
Okay.
Thank you. Yeah, we're trying to schedule a talk with Christus next year, and maybe we can get that information from them at that time. I had a couple questions, Andres. You showed us the statistics on the mental health calls from 911, or psychiatric calls, I believe is the term you use. Are you seeing a shift in the nature of the complaints or the issues that are causing 911 call? In other words, is there a big ramp up?
Now you're going to sleep? This is so boring for you. Sure.
Are you seeing any a ramp up in a different mix, I guess is what I'm asking.
Who was that?
We would have to, so I pulled the information for that specific complaint. And one of the reasons we're moving to a new software system is because our current software system is not the greatest for data analytics. So it's, I'll have to get back to you on whether the proportions have changed drastically. But you know, it would take some significant analysis. And not only that, our data is noisy enough that it's not truly diagnostic. It gives us a general picture, but as I mentioned, you know, there's so many overlaps in our calls. So a mental health call can come in as a back pain call, or as an assault call, or as a rape call, or as a, you know, any number of things. So it's really hard to answer that question with certainty. Yeah, I'll leave it to an epidemiologist to sort of parse that apart. You know, what is clear is the types. I'll share. Let's see if I can blow it up here real quick. What I have is our total call breakdown. So it's hard to get into the nitty gritty and answer more specific questions, but there are some general questions like this is the incident type groups for all of 2019. So as you can see, it's like big Pac-Man there. EMS, 78% of our calls. Good intent and public assist, another 15, and those can vary from a raccoon in an attic to someone in a wheelchair that has fallen to someone whose oxygen regulator is not, a concentrator is not working. So there's a lot of medical calls in the good intent and public assist category. So that's over 90% there. So it's hard to get into the finer detail when you take mental health. So the three dispatch categories that are most commonly associated with mental health and behavioral health issues: psychiatric, suicide attempt is one, poisoning overdose is another one, and man down, unknown problem. Those three are 25% of all of our medical calls. So it's a big chunk of our calls. And I'm sorry I can't get into finer detail on that. But hopefully with some more work, with some more resources, with some more attention being paid to these questions, you know, what we really need is curiosity around these. And I think that that's where the city is moving towards by combining police, fire, and community services, trying to start to share some of the information, some of the intelligence, trying to get better rounded pictures of the issues and also of the solutions.
Thank you very much. I have one more question, and that is, are there any ways you can see that NAMI can help the city and the fire department moving forward in some of the initiatives that you mentioned? I know you mentioned participating on this integration task force, but beyond that, are there any other things you can see that NAMI as an organization or its members can step up and help you help our family members and ourselves?
You know, I think as far as the city, that task force is a good place to start. Reaching out to your city councilors, to the mayor. But for me personally, is just sharing your input from your experience of how we have done as a fire department. You know, I'm like I said, I've learned quite a bit from interacting with you all over the years. So I'm very curious to hear, you know, this pie chart doesn't, it means something to me, but it doesn't mean as much as the texture that you can get from family members and people who have actually had to use the services. So, from an egoistic standpoint, please tell me, share your experiences with me as much as you'd like, and more from a city and structural standpoint, the task force, counselors and the mayor. It's good for them to hear your point of view. They really want to hear that point of view.
Thank you very much.
Can I interject here?
Please, Betty.
As you talked about the city looking at some behavioral health crisis models. You're talking about, and you mentioned some cities that had some good models out there. Is that a task force that's going to be looking at that, or is that part of the task force you were talking about?
Yeah, the task force has quite a bit of latitude to look at community health and safety issues. So I assume that they will be looking at that. In this first meeting, they're going to sort of start to plot the course of ideas they have and things they want to explore further. I think that this will likely be one of the key things that they'll focus on. And the new director, whenever he or she is selected, will be part of that dynamic. So we'll see where it comes out. There are a lot of promising models. I know that NAMI, you folks at NAMI have been talking about this for 3 or 4 years now, or if not more. So your input, I think, would be really helpful.
So do you know who's leading that task force, that we could maybe get our name on one of our names? Maybe our new president, Risha, could attend, or one of our directors?
Sure. So it's an 11-member task force. The co-chairs are Councilor Cruz Rivera and Councilor Rene Villarreal. If you go to the city's webpage, the weekly meetings list, you'll see it listed for the 17th. And then there's information there on how you can submit questions and input to the task force.
Thank you, Andres, very much.
Thanks.
I don't think I see any more questions.
Excuse me. This is Tina.
Oh, Tina, go for it.
Okay. I just wanted to add something, Andres, to your cardiac information. A lot of people make the assumption that people aren't calling in due to heart attacks. But when you look at the New York City data in April compared to last April, the April before, they went from 64 calls a day to 300 calls a day on heart attacks specifically. And it's clear that this disease attacks heart, brain, and kidneys in addition to lungs. And so the suspicion is that the heart attacks are coming on in a different way, that people don't have the symptoms they normally do to do the preventative calls as much. Just to give you a heads up on that.
Yeah, no, that's interesting, and I definitely do not claim to be a physician or a research scientist. What I was going off of is friends doctors at the emergency room who told me the hospital's empty. We don't have anyone here. Our call volume was down by 30%. Our call volume was down by 30%. It was a significant decrease in call volumes, but then I talked to the people that were stocking our medical supply room, and they said, all we're using is PPE and cardiac arrest supplies. So whether it's a cause or correlation, it's just an interesting relationship between a drop in call volume and an increase in cardiac arrest. So, I mean, yeah, thank you. I without knowing the root cause of all this, it's just an interesting correlation. And we do hope that people feel comfortable going to the emergency room when they're having an emergency, and don't delay care. That's really,
and another really important statistics that I try to push out to people so that they feel a little bit more better about going to the hospital. In the beginning, in March and April timeframe, it was unfortunately 25% of the people that went in with COVID didn't make it out. That number has now dropped to just 7%. The success rate is much, much higher, and don't hold back on going to the hospital based on your fear of all the stories on COVID. The success rate has gotten so much better. But seriously, you guys have no COVID patients hospitalized in Santa Fe?
No, what I mean is back in the spring, that first quarter,
Okay, yeah,
everything just shut down. There was now it's a different story.
okay.
Like you said, hospitalizations are up. Thankfully, the US rate, the cases are way up, but the fatality rate, even though it's still unacceptably high, has remained fairly constant. So you're absolutely right that the treatment for it has gotten a lot better, and doctors are much better at providing effective treatments and keeping people alive and getting them home.
Which was the reason for flattening the curve and shutting down and pushing it out. It bought us time. It really bought us time. And I don't know if people really understand the dynamics of a new disease and all that good stuff. But anyway,
Absolutely.
Thank
we
you
did our
very
job.
much.
We just don't get credit for when we're successful, as a society. That's okay.
Thank you. Cameron, question?
Well, thanks, Tom. And Andres, I was curious to the extent, and first, thank you for your presentation. You answered really all my questions with your prepared remarks, but I was curious to the extent that the opioid crisis and mental health issues can kind of overlap. Where are we now on the opioid crisis? Are things getting better? Are they getting worse? Is funding, better than it was a few years ago, or we still need help in this area? Where are things, just in a general sense, if not the numbers, but your feeling?
Yeah, I actually have the numbers right here. Overdose rates are increasing. I just finished preparing a report for a federal grant that we have, and this is local data. So these are there's the cheap screen share version. So blue boxes are number of overdoses. Each one of these is 1 quarter. So blue boxes are overdoses. The red boxes, which are not very visible, are fatal overdoses. So as you can see, our number of overdoses has steadily increased while our fatality rate has remained fairly constant. So sort of like COVID, right? More cases, similar number of deaths. So that means that tells me a few things, or that makes me wonder about a few things. But since we started the Opiate Outreach Project, this is fatality rate for overdoses, and it's gone from about 6% to about 1%. So I want to give some credit to the staff that's working on this, and also, I mean, to the broad community. There are more medication-assisted treatment options in town. There are more harm reduction providers. There's more attention to the problem. So we're doing, it's still a big problem. It's still an enormous problem. And to speak to the first part of your question, the overlap is enormous. So mental health and substance use have a really complex dynamic. And if you didn't have mental health issues when you started using substances, you could develop mental health issues from the sequela of substance use, and vice versa. So it's really hard to separate those two. We work with about 90 people at any given time. Most of them are addicted to opiates, and they're extremely complex cases. There are very few people who just have a substance use disorder. They're just using opiates, and that's their only challenge. It's a really complicated problem, and that's one of the reasons we want to expand beyond opiates on our criteria for working with folks, because that it's almost some days it feels like a somewhat arbitrary criteria, even though we have way more people dying of opiate overdose than a lot of other things in town. So that it makes a lot of sense to focus on opiates as one risk, but it's a complicated dynamic, and the numbers continue to go up. New Mexico, as you all probably know, has a generational opiate crisis. It's not the sudden opiate crisis that came up in the Midwest. This is going back to the Chimayo and Espanola, Rio Arriba County in the 60s. So our numbers, we were always the top of the charts, and some states have overtaken us, but we're still facing a lot of challenges. There is more federal money available. I believe it was Purdue that just did a big settlement on a civil case, or maybe it was a criminal case. The city is party to one of the lawsuits with a multi-district litigation on opiates. So we're paying close attention to that. So there are resources, but you know, some of these problems, what we need the most, instead of money helps, but what we need really is community connections. We need people to help each other out, to support each other, to be there for each other, to hear each other out, we need to reduce stigma. We need to improve access. Yeah, thanks for the question. It's a complicated dynamic between those two.
Oh,
Thank you, Andres. Seeing no more hands up, I want to thank our speaker. Thank you for joining us tonight and updating us on what the fire department's doing in support of mental health and a few other topics as well. We've had a great partnership with you and your organization for many years. We're looking forward to continuing that. And thank you for all the good information you gave us tonight. Betty, do you have anything more, or are you just, your hand appeared?
That's my clapping hand for Andres.
Oh, okay. Well, let us all thank Andres.
Thank you, Andres. I don't have anything else. Thank you. Appreciate your
Excellent.
time to always be available to us. I really do
Absolutely.
feel like we have a very true partnership. That's great.
Thank you so much. Yeah,
Thank
and
you.
honestly, what I said, I mean, if you all have any input to provide, you can call me, email me, get a hold of me through Tom. That's really you guys are experts in this field. I am trying to figure it out, and I think a lot of people at the city are just trying to figure it out. So your input is extremely valuable. So however you can get that to us, whether it's through the task force, whether it's through advocating through your city councilors, whether it's talking with me directly about client services, and we're all ears. So thank you guys for joining us tonight, and stay safe, wash your hands, wear your mask.
Good night,
Bye.
everyone.
Good night.
Okay,
Thank you so much.